before the existence of Triage in NTRH, in fact, most of the patients used to succumb because they could queue up with other patients, because they could get maybe only 2 clinicians in outpatient out of maybe 100 and something patients per day. So most of them, in fact, they used to succumb in the waiting bay, because maybe that time there's no time to take history, suffer more, because most of them even could succumb while still on the waiting bay.
Patients used to take a lot of time. Yeah.
Okay, how are you? Okay, we'd like to be talking about the Triage before you came on the board. We had some problem with our patients because we didn't have because we believe a Triage is a heart of the hospital. So before we didn't have that heart of the hospital. So patients, maybe most of them, they were treated in the places that are not supposed to be treated. Maybe some they had emergencies, but they never got that chance to be treated early. So before our doctors had a lot of time because they had to triage the patients. Maybe patients of high blood pressure, they were not yet diagnosed, because in the triage right now we have a easy time, we can diagnose them the early stages, and we repeat it severally, and we advise them, and we escort them to the nurses and to be given the medication to lower their pressure, and we repeat it multiple times. But the time before, it was crazy, because they had to go to the doctor. Maybe the chances were not that well, and doctors has a lot of queue, so he has no time to take care of that patient throughout. So he missed a lot of opportunity.
Even others used to be threatened by relatives, even being beaten by relatives, because of they could not understand whether maybe there's a delay. When there's delay in maneuvering the patient to the clinical officer, always there could be chaos. In fact, even physical fighting. Yes.
The patients used to be too many, no direction. They are mixed up. Yeah.
Before the RURA, there was no triage at all. We used to overwork. In fact, we used to see all the patients in outpatient, no triaging, no nothing.
Any emergencies come through, is detected first in the triage, and they are directed to the light prices.
The triage now, we have got a lot of confidence with our emergency department team, where when we triage, they're on their feet to call the EMOS. Now the RURA, since the RURA came, in fact, it's perfect. We know how to triage, and now patients are enjoying, because they are going to the respective areas where they get first aid.
Triage forms which made the work easier. Yeah, now the patients could be taken out to patient, emergency, and the time was good. Yeah.
Right now, we are in a good position that we say our patients, they are getting the best care, and they are treated well, and they are taken to if they're emergency, they are taken to the emergency. If they don't have any emergency, they are taken well.
Oh, because there is the existence of Triage in NTRH, there are no chaos between relatives and staff, because when relatives bring in their patient who are very sick, they need first attention, and maybe there are only 2 clinicians. Now, because the Triage has really decongested this, because most of our sick patients, very sick patients, when we triage amber flag or a red flag, we always take them to emergency department. That's now decongesting the outpatient department, and there are no more care. Triage has done a lot of good work to our hospital. Now we are really decongesting the outpatient department. We are only taking their stable patients who can even wait for even 2 hours on the queue before they are seen. But in Triage, we take those who are urgently, who can even succumb before even 30 minutes. We take them to emergency department for more investigations and more management, senior management. the challenges were, especially when there's an accident, everybody could just flop in, even the relatives could flop in the outpatient, causing a lot of chaos and congestion. The clinicians there could get confused because they have to call the MOs on duty to come and assist them. But nowadays, since the ruler came, you can get a lot of care in ED, through ED, because you triage right away from the ground. Then you take the injured patients to emergency department, where they are prioritized and given efficient and a very complex management.
About the challenges we had before, it's like a patient didn't understand the reason of coming to the triage and why they should be triaged, because most of them felt like it's time wasted and they needed to see the doctor without getting triaged. But we overcome it because we explain to the patient that they need to be taken the pressure, taken the history, that make us understand and to be able to identify if the patient has a emergency treatment or it just like you can just go to the consultation without any assistance. So the patient, through that, they understand it, and right now I think we have in a position that patients understand, and even the doctors understand that like every patient has to pass through triage. So it has become easy going for us, and I could like and we have also have like posters that have been posted in the outpatient consultations and everywhere in the hospital, that makes people understand that triage is the most important thing in the hospital and is the first treatment, because if you are diagnosed with anything or any emergencies come through, it's detected first in the triage, and they are directed to the light prices. Then more I could like maybe like more education for the patients, and we continue. The education is there, but I think every time, because we are getting new patients from every day, so it's good like triage can be put because right now in our hospital we don't have a real triage. So I could like maybe it could be addressed and we could be having a real triage that patient they can be like this the start. Before, like the way we have like we have so many places that every patient know that they have to register before getting any service. So I think it could be also the triage that is a place that is real triage, not moving, because we have been having challenges of moving this way. So patients, they are getting also confused that where is the triage. So I think it's good like we having a triage that is written triage and everything, and it will be helping to the clients, because I think our community are the people who want to be helped, and they feel like if they get best help they can. So
yeah, the challenges that we're having in emergency department, we have got only 3 beds and 2 stretchers. You see, when you have got a mass accident, you cannot accommodate everybody there, because there are only 3 beds and 2 stretchers. And you see now, you cannot put a patient on the floor, or those bleeding, you cannot make them share the beds, not the stretchers. So maybe in future, because they are putting up a new emergency department and triage department, we hope for the best, because maybe they are going to purchase for more beds.
okay, I could like to address some cases that we found in triage. That's why we are saying that triage is helping a lot, because we had a case of an age of 17 to 14 years child, is a girl, and we discovered like the patient had a bleeding that was non-stopping. So the patient was colored red, that was supposed to be taken to ED. The patient was age of 17 to 14 years old. She was had abortion that was incomplete. So the patient was not that free with the parents, like we want to express everything, because abortion in our country, in our community, is a crime. So not everybody freely to talk. But in triage, I'm thankful because we have the nurses that are so friendly to the patient, that the patient get openly and they can share their problem and say something that you cannot say to the relatives or the person who brought her to the hospital, because we make like a patient's information, they are kept confidentiality. So the patient came and explained everything to us, and the bleeding was so, the patient was like getting pale. So we realized it, and the patient was rushed to ED, and afterward was taken to the ward.
There's a lady who came with the infertility. Then she had a very negative attitude, but when I talked to the lady, she calmed down. So that's the time I took the action of referring the patient to a clinician and making a follow-up so that this patient can be booked a gynecology clinic for review by a gynecologist, thus making the patient have hope of conceiving.
There was a patient who came in the ICU, and she was taken care of very fast, and she came out well, and she came to thank us for what we did. Yeah.
Also, there was a middle-aged man who came to Triage with a difficulty in breathing and low respiratory movements. I went and took a wheelchair. Then I tried the patient, took a wheelchair very fast, and took the patient to emergency department where they did the CPRs. So I say it's a success, because if it were the way it used to be formerly, the patient could have died, succumbed on the queue. Yes. Example, when maybe there's a snake bite, that patient, we have to ask the type of snake, the color of the snake, the time that the patient was bitten. Then we tried the patient to emergency department where they are given venom and maybe even hospitalized, because depending on the patient, there are other snakes which are very poisonous. They make patient vomit, they make patient to feel chills, and even to have a DIB. There's a middle-aged lady, a young lady, sorry, in her late 20s, came with a puffiness of the face, diminished urine output, edema of the body, then with the DIB. Then when I tried to ask her questions, she was in pain that she could not talk. Later, she calmed down. Then she told me she was taking a lot of water, but the urine output was diminished. That time I took action. I took my observations. They were not normal. The BPs were elevated. I wheeled the patient to emergency department where the patient was stabilized, then later taken to the wards after the lab requests results were out. She was found to be having renal failure. Currently, the lady is still going on with the dialysis. She comes twice a week. In Triage in Kenya, in future, it will be something very nice, because we'll be classified like the KNH, the National Referral Hospital, the KNH, because we'll have time to know which patients belong to which doctor or the specialist. Then maybe in future we'll have a lot of people specializing for the kind of illnesses or diseases that we encounter in Triage. Because right now, when we get something like maybe hemophilia, we have to refer that patient. But when we triage them, when there are many, then maybe the hospital will consider the training or specialization of our MOs, even nurses. Yes. I can take example from where I come from in Western Province. There's no triage there. then you know there are a lot of snakes, there's a lot of malaria, there's a lot of sickle cell, there's what. So when maybe the rural extend their departments to other hospitals in Kenya, I think it will be easier for them to be triaging the patients, then channeling them to wherever they are supposed to be channeled, and there'll be no, maybe the death rates will go low.
Where I see like Triage in future in country and in this hospital, I can say that it's a good start and it's a good thing, because we are in a somewhere that I could like even in rural areas also to have the same programs, because when we have like when Grace came and others came, Elena, Jordan and everybody, they were able to coach us on writing Triage papers that we are able to diagnose easily and to get the history of the patient, that help us to help the doctors also to reduce the queue in the clinic office, like in the consultations, because you write every the history, if the patient is using any medication, is he has any like allergies or anything, so doctor is able to detect before, because if the doctors have a lot of work, they are not able to ask all questions for the whole patient and took the real history. But the Triage being the art of the hospital, I feel is a good start, and I could like even the program if it could help us go to the rural areas that we have so many hospitals. And right now in Kenya, we feel like rural areas, there are the more people going there, because they feel like in rural areas, like in the health centers, they don't pay much, not like in the referral hospitals. So a lot of patients, they are in the rural areas. So I feel the program can also be also here, but still can move to rural areas, because we feel a lot of patients, they are there and they are not getting the feel the real treatment. So like for pressures and DMs and everything, I think is a good start for the hospital, and we have seen like entry rate growing so fast, and making like the whole hospital understand like Triage is the heart of the hospital and everything is working well with us. So I could just say like I love it, and I could like it to be focused. Like we have our neighbor hospital, is like our small child is in Liki, there is another one in Kararo, there's a lot in Kenya, but in Laikipia we have so many, Idoldo. We feel like if the program expand and get to catch up the other health centers, we are going to be in a good position, and we are going to help so many patients to diagnose their diseases and to get best care. Thank you.
What I can just add about what I've said is when maybe we get chance to go to UK and maybe see how they carry on their Triage, because we have not seen them, but we are being taught, like for example like Grace, Elena used to come and teach us, and currently we have got Grace who is doing her best, and Tia is coming. So maybe when we get that privilege to go and see how Triage goes on in the UK, we can do better.